Paula Bradison here, calling in, dialing in this morning, if you will, my old school speech with Natalie Treadwell from the Alaska Executive Search and Bradison Management Group offices. We're our tiny little huddle of two this morning and enjoying this beautiful Alaska morning, and happy to welcome both Preston and Aaron from Providence, my old stomping grounds. I spent 20 years on campus at Providence, and so this feels like old home week for me. I'm happy to hear from you, and happy to hear from you, and proud of AEDC for these voice sessions that Bill and his crew have put together. It's good to see how Alaskans are able to pivot in this new strange world and come up with ways of staying connected and informed and hopefully healthy. So looking forward to today's talk, and thank you so much for letting AES and BMG be a part of this, and happy to see all of you online. Good morning.
Thank you, Paula, and thank you, Alaska Executive Search and Bradison Management Group, for your ongoing sponsorship of the AEDC Voice webinar. Good morning, everyone. I'm Bill Popp. I'm President and CEO of the Anchorage Economic Development Corporation, and I want to welcome everyone to the first AEDC Voice webinar of 2021. We're so glad you could join us. Today we have another great program highlighting Providence Health and Services, a key healthcare provider of Alaska and member of AEDC. Joining us today from Providence are Preston Simmons, Senior Vice President and Chief Executive, and Aaron Martin, Executive Vice President and Chief Digital and Innovation Officer for Providence. Mr. Simmons has served as a leader within Providence since 2007 in a variety of roles, including Chief Executive Officer of Providence's Northwest Washington region and Chief Operating and Administrative Officer of the Western Washington region. Mr. Martin leads digital, marketing, and ventures for Providence and is also the Managing General Partner for Providence Ventures, where he is responsible for early stage venture technology and device investments for the $300 million Providence Venture Fund. Preston and Martin, thank you so much for joining us today. I'll hand it over to you.
Great, it's a pleasure being here today, and I'm going to start off the presentation with a couple slides and then hand it over to Aaron. And Aaron's an absolutely amazing colleague and has led the efforts of our digital transformation as an organization that I'll talk about here in a moment. And take me a moment to share my screen. Can everybody see that okay? Okay.
Yes, we can, Preston.
Okay, thank you. So our road to transformation, what this is our vision for healthcare in the future is health for a better world, and what we're calling healthcare 2.0. Historically, Providence was an acute-centric organization, and a journey started probably about 7-8 years ago to really start transforming us into a system of care perspective where we have our patients, consumers, and community at the center, and that we're digitally enabled. And pre-COVID, I would say we were at this central point, but really through COVID, we've accelerated probably what was 3 or 4 years worth of effort into this last year in terms of bringing these different components together. And Providence, Alaska is almost like a system within a system. We have many of these elements that are highlighted here, this as a representation. Everything from acute care hospitals, children's hospitals, ambulatory surgery center, retail clinics, primary care, airlift services, home services, and have advanced considerable amount of innovation in both telehealth and digital tools. And really, we've done this for focusing on 4 different domains, but really reimagining our operating model. So we've looked at what should be provided locally, what should be provided on a regional basis, what should be provided from a system perspective or even globally, and really want to have really driving towards best practices in everything we do from both a clinical and an operational best of breed standpoint. Really redefining the value chain. We want to make sure that we're serving patients that experience of care, having the highest qualities of service, access, safety, and quality. And a part of that is in the rebuilding the organization is really trying to make care more affordable. And we have often hear about how costly healthcare is in Alaska. And I think we've made great inroads. A lot of the data that has come out that has been shared has been based on 2014 data. But if you go into the most recent 2020 information that's on Kaiser Family Foundation, and it looks at cost per hospital inpatient day. Alaska now is about midway among all the states in the nation. There's actually 25 states that are higher on a cost per patient day. And we continue to drive that affordability and value components, and I know how important that is to the business community that's out there listening to this. And really we're transforming that care model so that can be passed in through the payers or direct products to businesses. And an example of that is that we were just awarded the state of Alaska contract that started on 1/1 because of a lot of the work that we've done over the last several years to really drop cost of care here in Alaska. And then the other way is connecting our communities in new ways. And that's really about how do we do deeper partnerships? How do we do innovations? How do we kind of do what we do best and partner on the rest, so to speak? And examples of that are in the areas of homelessness or behavioral health, or partnering with other community members throughout the street to really drive what is a system of care within Alaska and really transform what we have is an economic model of fee for service to one that's value-based care. And at some point we'd be happy to come back and talk about that, because that's going to be important for the transformation of healthcare in Alaska. And our team truly believes, and others, that that a vision for Alaska, that we can be a model for the rest of the country, because the leadership exists in Alaska to be able to do that through partnership. And we've seen that in many different areas when we all focus as a community of leaders on initiatives. One thing that we do every year as a system is Rod Hockman, Dr. Rod Hockman, who's our system CEO, does annual New Year's predictions, and there's 10 of these laid out here. And the one that we're actually going to be focusing on today, or actually two of them, are telehealth momentum. I'll talk about that later in the presentation. And then the work that Aaron leads is around the innovative digital tools that are just absolutely remarkable of how we're connecting to patients in new and different ways in our transformation to help to make care more seamless and connect patients throughout their entire life cycles. So Aaron, I'm going to turn it over to you at this point.
Great. Thanks so much, Preston. Can you guys hear me okay?
Yes.
So, the Providence Digital Innovation Group kind of has three vectors or things that it kind of works on across the industry. The first is, we typically collaborate closely with technology companies, both small and large. So think Microsoft, Amazon, Google, but also small technology companies that in some cases we will actually invest in. We engage with healthcare consumers, so that's not just our patients, but anybody who's seeking information about health. And then we also try to proliferate and de-risk technologies across the healthcare industry, beyond our own four walls. And so to give you a sense, pre kind of COVID, we'd met with about 125 health systems for, anywhere from kind of 3 to 4 hour kind of timeframes in Seattle. Now we're doing those meetings virtually, just kind of transferring best practices and some of our knowledge around digital that we learn, and then also gaining access to kind of, lessons learned from our colleagues and peers across the country. And it's really kind of leveraging the structure of the way health systems operate in the United States. We typically are very regional. We're a large health system, but we have maybe a handful of competitors and in specific regions. But for the most part, the 200 or so other major health systems across the country, we don't compete with them, and so it's a great way of kind of transferring best practices in terms of new business models, digital techniques, et cetera. So we do a lot of information sharing. You can go to the next slide. This is our innovation model. What it starts off with is trying to identify where we think there are needle-moving opportunities for digital, where it will make a significant difference in either clinical impact or financial impact, or both, to the health system. So, how can we deliver, on the quadruple aim of, higher quality, lower cost healthcare that's more patient friendly and clinician friendly. And so what we do is we take a very kind of methodic approach to that. We do a lot of research. We talk to a lot of organizations and a lot of folks within Providence itself. We stack rank these priorities, and then we walk them through a pretty robust process. The first one is we, of course, determine in our existing portfolio, do we already have a solution to the problem? If we don't, then we'll actually send the opportunity over to Providence Ventures, which is another team that I lead. They go out, look for what we call best of breed companies, and then basically try to find solutions to problems out in the marketplace, and we will bring them in, make introductions to the health system, and then sometimes, but not all times, we'll make investments in them as Providence Ventures. Right now, we actually have closer to 22 active portfolio companies, 5 of which have what's called a unicorn status, meaning they're worth more than $1 billion. And so, this methodology of kind of starting with the problem and working our way backwards seems to be working from a kind of a portfolio de-risking standpoint. If we don't have it and we can't find it through Providence Ventures, we will actually build it. And so we've done that 3 times so far. So of the 22 portfolio companies, 3 of them are companies that we actually created. And this is kind of another kind of leg of the stool of marketing, digital and Providence Ventures. The digital piece, we've got 125 software engineers and product management folks, a lot of them from the same kind of backgrounds that I have from Amazon, Microsoft, places like that. And what they do is they innovate in areas where we can't find a good solution in the market, and we create new companies out of it. And so we've done that 3 times before. The first one is with a company called Xealth that allows our clinicians and now clinicians from 10 other health systems across the country, since we spun it out, to prescribe anything that's not a pharmaceutical as if it were one, directly from the EMR. So think of, the way that you might prescribe a drug. You go into the physician's office and they obviously recommend, say, a atorvastatin for, cholesterol or something like that. In the same way, they can now prescribe anything else. So they can prescribe, a digital app, a service, anything else that, and then have it be fulfilled through our digital platform on the back end. So it's really novel technology. And then DexCare was a key part of our response in the COVID pandemic. If you go to the next slide. So digital insights. So this is for the first time ever. We actually published, and you can find this at providence.digitalinsights.org. Because we typically do this deep research every single year, and we refresh it, and we talk to our counterparts in operations like Preston and his team. In this case, we talked to well over 100 folks in the context of COVID, and we actually published our these insights to the broader community, and it's had a huge reception. And the reason why we did this is because we were pretty humble in the knowledge that we didn't have all the answers, and we wanted to kind of again check with the industry and just get reaction and feedback to what we thought might happen and how digital would play a part in the COVID response. Our response, and Preston will go through some of this in later slides, was pretty robust, and it's fortunate that we had made the investments we had in digital prior to the pandemic. So for instance, we had built a big digital presence that allowed us to communicate at scale with patients, especially in the Seattle market when COVID really first hit. And then, so we were able to kind of communicate, with patients at scale. And then patients who were concerned, whether or not they might have been exposed to COVID, we deployed an AI bot called Grace that we'd been working on for a couple of years that was able to answer in a conversational manner with patients, ask them questions about, their exposure risks, symptoms, et cetera, and then push them if they were under kind of at risk and they needed to be evaluated, push them into our digital platform that allowed us to do on-demand virtual visits through a platform we built called DexCare. That then allowed a nurse practitioner to see these patients safely over a video visit, because keep in mind, during the response, we had a severe lack of PPE and we had to shut down a bunch of retail clinics because of this. And so this allowed us to keep caregivers safe and patients safe. And then if they were at risk and we decided that they weren't ill enough or at risk enough to be admitted to a hospital, we were able to monitor them at home through a couple of portfolio companies that Providence Ventures had invested in. One I already told you about, which was Zelf, and another one called Twistle, which allowed us to do remote patient monitoring. And the way that worked is allowed us to, send the patient home with a thermometer and a pulse ox, and then monitor them remotely from home. And then if they decompensated or got worse, we could then do a video visit and then admit them. So a lot of the digital tools that we'd had, kind of developed, over the past, 7 years thereabouts came in use in the digital response. And then also we published this research where we think things are going to be headed from a healthcare standpoint going forward. You can go to the next slide. These are some of the areas that we're focused on. I've talked a little bit about distributed care and digital access. This is how we're going to engage with consumers and patients more effectively. We've been doing a huge amount of investment in this area to make, kind of care more convenient and easy to access through digital. Navigating patients to the right venue of care. So it's one thing to be able to access care. It's another thing to make sure that they get to the right kind of care that's the lowest cost, most appropriate venue of care. So we've invested in smart assistants and surgical concierge and consumer engagement platform. And then also making sure we're supporting our most vulnerable. So we're starting to really, really work and dig in hard on how do we serve the underserved more effectively through digital? And then finally, as an attachment to that, obviously extending and scaling behavioral health. We've made significant investments in that area, and we want to be able to provide digital access to mental and behavioral health, regardless of where the patient enters into the health system. You can go to the next slide. This is kind of the pipeline of innovations. You can kind of see, I was talking about before, if we can't find something out in the market, we'll identify a white space and actually start to build technologies around it. There's a lot of uncovered space in healthcare. And so we've spun out 2 companies so far. We're in the process of spinning out a 3rd company right now. And there's a lot of work behind that. Go to the next slide. This is an area that we're very, very interested in, which is building unified access to for patients digitally. And so this allows us to right now, if you download the Providence app, you can get access to your EMR information, so your health record. You can get access to retail locations, video visits. What you'll also start to see over time is when clinicians start to prescribe other applications. This is where you'll kind of pick up your digital prescription for, say, for instance, a behavioral health app, a diet app, a diabetes prevention app, content, products, and services through the Providence app that we've rolled out. Go to the next slide. This allows, you can see here that this is how you kind of access through the Providence app anything that you need to know about your health, everything from messages with your clinician, test results, medications, billing, et cetera, and as well as accessing, virtual visits and, being able to schedule in-person clinic visits. And then again, access some of the content that I was talking about before that your physician may recommend to you. Go to the next slide. And then also we've deployed Grace, which is our AI chatbot, into the Providence app. So what Grace does is help navigate you to the most appropriate venue of care instead of you having to kind of access, say, a call center or find it yourself over the internet. And it does it in a conversational way. And again, this is a big tool we also use to kind of navigate patients to the right response in COVID as well. Go to the next slide. And then finally, we're starting to work more and more with employers around and payers to kind of integrate their benefits into this app so that you don't have to go to 5 different places to find information about your healthcare. Next slide. So with this, I'm going to turn it back over, I think, to Preston. He'll talk a little bit about some of the work that we've done in telehealth.
Sure. Thank you, Aaron. So there's 2 hubs within our system for telehealth services, our main hubs. One is in the Seattle area, and Anchorage, Alaska is the other one. And we, during the height of COVID outbreak, for example, in New York, we were providing tele-ICU services here from Anchorage, and we routinely do services down to parts of Oregon and Washington State. These are our panel of services we have: telepsych, telestroke, telehospitalist, tele-ICU, EEG. On the ambulatory side, we have behavioral health concierge. We're working, I'll talk about it in a moment, kind of at that COVID at home monitoring. And then we're going to be one of the pilot sites in Alaska here for Providence at Home, and that's a hospital in the home concept. And all these innovations, I think there was a question in the chat line about, the cost of care and how does the digitization and the tools we're utilizing transfer over into premiums for companies. And part of that is by us being able to keep our costs down, then that will ultimately, hopefully, translate through our insurance partners into companies, as well as direct-to-employer contracts. And in terms of that, moving from fee-for-service to a fee-for-value system, where you're really connecting and partnering with patients and the providers in the community, you're able to eliminate a lot of waste and duplication of services and testing and so forth. And so that's a big part of this transformation to a digital company. And I can talk more about that a little bit later in the question and answer session as well. This is our telehealth kind of footprint. In Alaska, we have community connect partners. And you can see services to, throughout Anchorage, Palmer, Valdez, Seward, Homer, Kodiak, Unalaska, and others. And our visit counts there for telehealth services. One of the things we've also brought up this last year, which will really help transform care in Alaska through shared information is a health information exchange. We have a product that was developed in Southern California that actually connects in about 50 different types of EMR systems. And we brought that to Alaska this last year, and we have about 20 partner organizations that have been signed up on that already. And it allows sharing of testing and EMR type data, such that a patient that shows up in one of a primary care clinic that's not affiliated with us, for example, in Anchorage, we'd be able to see the information if they ended up getting admitted to our emergency department and have that knowledge of what happened with that patient if they came in through another care setting, and hopefully would not have to duplicate tests and treatments. Also in things like would have been very helpful to have had that in place already, of sharing knowledge around COVID positive patients and so forth in our community. But that will be something that will be fully rolled out this next year. The top 5 departments by patient volume that we've been using telehealth, you can see here, behavioral health, internal medicine, family medicine, pediatrics, and maternal and fetal medicine. Those are kind of top patient volumes this last year as these have been implemented. The other thing we did, and Aaron talked a little bit about this, but when COVID started, we put in this home monitoring system in place where we send out a pulse oximeter, thermometers, and then have nurse telephone calls along with the Thistle product that was talked about. We've actually since March, when the first patient was seen down in Everett, Washington at the Providence facility down there in the nation, we started implementing this up here as a way to augment the bed complements throughout Alaska. And actually we had 618 patients that have been home monitored during that time, and it kept those patients out of community emergency departments. It kept patients, in many cases, from being admitted to the hospital because they got earlier interventions. And so, as you know, one of the things, we have some of the lowest bed to population ratios in Alaska in the country, not only in our acute hospitals, but in the nursing homes. So this was a valuable tool to be able to augment our clinical capacity within the state of Alaska. This is an example of kind of the conversion, and this was a period of time of March through July of kind of what happened around outpatient visits and encounters. There was about a 40% drop within our entire system, and this is not unique to us, but throughout the country this happened where patients didn't come in and deferred care. And then because of the investments that we had made, and Aaron and his team led, and others in our physician enterprise over a multi-year period, we were actually able to convert literally overnight. We brought almost 10,000 physicians online to virtual visits within a couple-week period. And if we hadn't been investing in this, we never would have been able to do that. In Anchorage here, we had just implemented a program of retail clinics, and we were able to convert those over and use those providers into virtual visits literally overnight. And so that, once again, helped people to get access to care without having to come in to the emergency departments and overrunning those, or going into outpatient settings where they would have potential exposure to COVID. Since that time, we've actually rebounded in total visits back to pre-COVID levels. And that orange line that you see at the second from the bottom, that's the ramp up from kind of virtual encounters. And that peaked up and then came back down to what is a level that's much, much higher than pre-COVID. And we actually, it was amazing that we probably did 3 or 4 years worth of evolution in those few months period. There was just a study that was published in Robert Wood Johnson that I just saw came out today, that nationally 14% of basically pre-COVID, 1% of all visits were done virtually. The first part of the COVID response, about 14% of all outpatients, and then that stabilized to 6% now. 1/3 of all adults in the nation have seen a telehealth visit since the time of the first COVID visit. So telehealth and those type of encounters are here to stay. Our level of stability here is actually higher than that. We've been consistent now at about 10 to 12% of all visits, and I think we'll see that into the future. So when we're talking about that quadruple aim, where we're trying to work on patient experience of care, where we've created access, service quality, and patient safety, that's really been enhanced in that care experience piece. This has also really enhanced the affordability. I have a slide coming up on that next. It's a way to reach out to the population in new ways and improve the health of the population, kind of that third domain. And then it's created better ways for our clinicians and our caregivers to see patients. So it's enhanced kind of from that perspective as well. So it really hits on those 4 domains of that quadruple aim. Providence ExpressCare Virtual. This is one of the innovations up here. And this is something that we rolled out into our system about 3 years ago. And then we had some negotiations, or actually some partnership dialogue with public information, public education health trust up here in Alaska. And we started talking about the ExpressCare Virtual and ExpressCare clinics, and this was something they were very interested in. So we made a commitment to set up 5 of these in the Anchorage community, and they're open 7 days a week when we first the physical sites. And then, as I noted, we converted literally overnight to virtual settings, and now 3 of those are back open to physical, but they're open from 7 a.m. to 7 p.m. They treat the 100 most common conditions that you would traditionally go to an emergency department for, but shouldn't. And they accept most insurance, and the cash pay price for a virtual visit is $79. And for an in-person visit is $149. And if we can't help you, there is no cost. And we'll refer the information for that visit. We want you to get continuity care, so that information will be transferred to your primary care physician. And if you don't have one, we'll get you signed up so that you have continuity of care. And this is really good for those after-hour times, especially for families that when you might need a visit, and your kid has the sniffles, you're worried about them, those type of things, or you need a vaccination or something like that. And so really substitute where folks would go to the emergency department after hours on weekends. So this is a lower cost, immediate access type service. You can walk in, you can set up an appointment there, you can do an appointment on your computer, you can do an appointment on your smartphone. So very cool. And then it ties into an electronic medical record and those MyChart applications that Aaron was talking about earlier. We did 126,000 virtual visits system-wide in 2020. And we did 5,400 of those in Alaska here in 2020. So it's been a very quickly adopted. In fact, we went from we actually in Alaska did the fastest start of any region. We were full within a 3-month period in all our sites when we first initially started these. Another innovation that we did was on vaccine distribution within our system. We created a tool called Validate and Verify. And what we did is we gave by job code and location for all 120,000 caregivers in our system a scoring. And then we asked them to do a self-score that did an amalgamated score. And then that gave a priority ranking for vaccine distribution throughout our system. And within just the first few months, we vaccinated over 80,000 caregivers as of last week in our system, which was actually a national leader in that area of getting vaccinations into arms quickly through those innovative type of tools. We have about 6,000 caregivers and medical providers in Alaska under the Providence umbrella. And as of last week, we had 4,000 vaccinations done. Pretty impressive in terms of using those type of tools and coordination as well. That was the last thing that I wanted to talk about, and I would open up to questions.
Thank you, gentlemen. Really appreciate this presentation. This was very informative, and we deeply appreciate you taking, appreciate you joining us for this.
Introduce yourself.
Yeah. Hi, I'm Natalie Triddle here. I'm with Paula from AES and BMG. I do have a question about the web application and how you've been integrating support for patients to be connected with local providers and still have access to the same admin support that they would get in an in-office visit. And you know, my experience with the app, I was actually connected with a doctor in California, and was still charged for the visit. And it was, in my experience, it was difficult to get admin support on the phone for the app in regards to the visit. So how have you been navigating kind of providing full service care through the application?
Yeah, there's a couple of things. First of all, you probably shouldn't have been connected to somebody in California unless they had licensure in Alaska. So I'd love to kind of find out more about how that happened. But generally, there's a couple of different ways that you can access virtual visits. One is through this on-demand virtual visit platform that you access through the app. That's for kind of like low acuity urgent care types of situations. And the second one is directly into your primary care provider. And typically how that happens now is you go onto the website, you can kind of schedule an appointment, and you can schedule it as either in person or virtual. What we're trying to do is actually make that a much more kind of seamless experience between you and your local provider, which is, believe me, is complicated, because once you get into, you know, kind of broad primary care, the number of different things that you could have at issue goes from kind of, you know, the top 100 to literally thousands of issues that the primary care provider has to, might have to kind of accommodate. And so one of the key problems that we're trying to solve is how do we first allow the patient to, without having to speak to an administrator or somebody over the phone first, self-select, you know, virtual versus in person, right? And what I will tell you is, like, you know, I'm based in Seattle, you know, I'm a patient with Swedish, and, you know, I run digital, and I screwed that up. So I scheduled a virtual visit with my primary care provider, and she kind of wagged her finger at me and said, you know, I can't do this visit this way because of the complaint you have. I need a physical visit to kind of physically examine you. So it's a complicated problem that we're still kind of trying to work through. That said, we've got, we'll probably do 1.6 million virtual visits now in 2020, and it'll definitely probably stay the same, if not increase over time. So we're seeing it at scale. I would tell you that we see at scale on-demand virtual visits and video visits, the vast majority go off without a hitch, but we still are running into these edge cases like you ran into, where we're trying to make it self-service to where you can just kind of, point and click and go, and make it intuitively obvious for you to access the right venue of care. I can talk for hours about
Yeah, I'm sure. And there's a few questions in the chat, so I'll read those out for the group as well. But is there a customer service line associated with the application with live customer support for those?
Yeah, there is. There
Okay.
is. It's a PEC, is what we call it, the Patient Engagement Center, and they generally support the app as well.
Okay,
Yeah.
great. Okay, so a question from Trish Baker. As an employer with several entry-level staff, affordable health options are key for both employers and businesses. It seems the efficiencies associated with digital care would translate into lower insurance premiums. Has this been the case?
Yeah, I think it's starting to. And so just to kind of, I'll take this and then would love to have Preston kind of jump in. The key thing that has to happen is we're the healthcare provider, and then we effectively provide our services to the payer, and the payer controls the rate, right?
Mm-hmm.
And so it kind of depends on the level of partnership between the payer and the provider, and how coordinated we are in trying to kind of lower overall rates. And so we don't have a lot of control over the premium that's being offered to employers. But what I can tell you is our cost basis is going to go down over time with the increased use of digital on a number of different dimensions. One is we can take the same resource, so take for instance primary care, and spread that resource, especially in a state as big as Alaska, over a massive geography where it just wasn't practical in person, right? So that's like one big promise of kind of taking and driving up the utilization of a typical primary care, say nurse practitioner. So to give you an example, in the ExpressCare clinics that Preston mentioned, the platform allows us to schedule visits down literally to the 15-20 minute increment, and it spots open slots across a wide geography, so that if we get a patient anywhere in the state of Washington or Alaska that needs care, we can put them in any of those open slots within the retail locations. So we were doing that at scale pre-COVID, and that allows us to kind of think about it this way. If I've got, like, say, a nurse practitioner based in Seattle, can see anybody in the state of Washington, not just their, the rather three mile kind of, radius that people would go to see her, in that retail clinic. And we can find open slots to kind of fill there. And so what that means is, from a cost perspective, is that person is being utilized more fully over time, right? And that drives down costs, right? And then the second way, from a digital, so that's the transactional piece, right? The second way it does it is navigation. So I think Preston talked about this. A lot of times patients, just because they don't know where else to go, they'll end up in the ED for something relatively minor that could be handled sometimes over a virtual visit. And so that's a lower cost venue of care. So if you compare the cost of an ED visit to, say, a $39 kind of, on-demand virtual visit, that is a lower price point, that the employer would pay. And then the last piece is, so you've got the transactional kind of scale, you've got the navigation piece of what digital can do. And then the last piece is what we call digital engagement, which is, the problem that we face as a health system, which is a good problem to have, is most of our patients, thank God, are relatively healthy, right? And so what that means is we only talk to them kind of 2.5 times a year. So the opportunity for us as a health system is to talk to them about their health between episodes of care. And if you put that into a population health context where we're trying to help them manage patients to live healthier lives, to lose weight, to, adopt better, habits, et cetera, between those episodes of care, we're actually going to reduce the number of times we see them for clinical visits and improve their health, which should, lower overall cost of care. So I probably way over answered that question, but Preston, what else do you have to add?
I'd say, well, you talk, as you know, we're 99% fee for service up here. So kind of the model that Aaron was talking about in terms of as we drop our costs, it has to be translated into the payer, and then they relate to the employer. And we have seen, as I noted before, the costs of healthcare have actually, from an acute side, have been relatively stable or going down, while the rest of the country has been going up for a numerous period, like a 4 or 5 year period. And I think some of the premiums that you're seeing on the exchange have gone down. And it's much more than, hospitals. It has to be providers and how care is done. The real change up here and what we're trying to work in setting in place is to move to that value-based care models. And that's through that connected system of care, having care done in the right care setting at the right time, done in the right way, having a primary care physician, working on those health promotion and wellness aspects, being navigated. And we just did a demonstration project for Medicaid in our residency clinic. And there was a remarkable reduction through navigation with that population that's served there of not having people go to the emergency department and having better outcomes. So those are examples. We're putting together right now a clinically integrated network with providers in the community. That will allow us to start doing things like bundled episodes of care. So if you have a knee surgery, for example, and that'll have an enabler through a clinical pathway that'll be digital through Thistle, like that. So it follows the patient through that and helps give them reminders and appointments and information of what they do post-discharge, during their case, pre, et cetera. So using those type of digital tools, working together as a community of clinicians, sharing knowledge management and pathways is going to drop our cost of care. And that is tied in directly through a partnership with the payer. So that way you're able to actually change the economic model for healthcare in Alaska. So that's the journey we're on. And as I mentioned, that's one of the reasons we just got a contract with the state of Alaska, because we're going to start working on over time some bundled payment arrangements in that journey as you go from fee for service to fully managed care under a capitation type arrangement. And those type of models will be able to directly offer those to employers in the community, and that'll should significantly help stabilize or reduce cost of care for you.
Thank you, Preston. So at this time, we're going to pass it off to Bill for a few questions.
Well, gentlemen, again, thank you for a great presentation. We really appreciate it. We're coming up to the end of the hour, and I think we're only going to probably be able to get in 1 or 2 of these questions, but I've kind of prioritized them. So let's try this one. So what are you most proud of in terms of your organization's response to COVID? And is there anything you wish you could go back and improve on?
Do you want to start, Aaron, and I'll go ahead and do it?
Yeah, I think, so my background is I spent about 15 years in technology before coming to Providence about 7 years ago. And I can't tell you, and there's been obviously many crises that have kind of occurred in the United States over that period of time, like 9/11 and the financial crisis. And you always feel helpless as a technologist, to not be able to kind of contribute. In this case, I can tell you, I can speak for my entire team. It was really, really gratifying to be able to both be a technologist and be able to kind of participate in some, albeit, relatively small way in terms of, protecting patients and caregivers. One of the things that we talked about was, the use of virtual remote patient monitoring and, the ability to, and some of the AI and chatbot technologies that we did. It was almost like virtual PPE, where there was no PPE in the market. We stood that there was a lot of very, very stressed out patients and caregivers who the worried well were about to kind of, show up at our doorstep at a lot of these clinics, and we couldn't serve them safely because we just didn't have the protection in place yet. And it was really kind of gratifying to be able to kind of contribute, the technology platforms that we did, to that effort. So that, I think that is, what we're probably most proud of in the last year. I think things that we could, do better, with respect to from a digital standpoint, I think, we've got the basic offering out there. And, the comment that somebody kind of brought up, about, seeing somebody in California or having problems, getting online with us, we still have a ton of rough edges to sand off. This is by no means, somebody asked for the call center number for support, right? It breaks my heart every single time somebody has to call and talk to a human about getting support for a digital platform, because to us, that's a failure in the way that our platform works. We consider that an error to go solve for. What we're trying to shoot for is removing as much friction from the care experience for both patients and providers, to where they can kind of focus on what we at Providence call the sacred encounter, which is, this really kind of focused relationship between the patient and the provider, and where they're talking about, their health, the medical issue and that kind of thing. And nobody's distracted from kind of the vagaries of the health system either way. And that's how my team kind of views our mission. So I would say more generally, like, there's just a ton of rough edges that we've got to kind of, sand off of the offering.
And from a digital perspective, I would echo what Aaron said, that what I'm most proud of is, I would say, the partnerships that were created across our entire system. And I would say, and I'm going to give just kudos in Alaska, because, they're here in terms of the leadership across the state, whether it was public or private, working together. And we had some of the lowest admission rates and rates of transmission in the country, and those areas. The innovation that came forward in the partnerships and the sharing of information nationally. The first COVID patient positive was in Everett, Washington, and the use of remdesivir and the 100 million mask campaign, and the sharing and partnership wherever we were. But I'd say just especially would thank all the colleagues in Alaska for everybody working together, and that includes you, Bill, jumping in. I remember when we were talking with the manufacturers around, in terms of the pipettes and how we could create masks and gowns, and ramping that up. You worked night and day on that, and that was just one of just thousands of examples of people working together, and that's what I'm most proud of the community responses and partnerships.
Well, thank you, gentlemen. And so our last question that I think will wrap us up here today: does Alaska create unique challenges for the healthcare industry? I'm sure that's a fairly obvious statement that it does, but we'd be really interested to know your perspectives on what those unique challenges are.
Sure, and I'll jump in on this one first. And kind of the obvious one is around the geography. And I think, as Aaron had talked about, the telehealth and telemedicine aspects is something we probably had not historically leveraged as much in terms of the resources we have as an overall system. And so we're really working to change that dynamic and bringing those tools that have been developed up here, and everything from that health information exchange, the virtual clinics, the hospital at the home concept, the digital tools that Aaron was talking about in terms of FISL and ZELF and the rollout, and really embedding those so that the entire community can use those, because we want, they're good tools, they're well proven, they will help improve, each of those aspects we talked about on the quadruple aim. But it's really about how do you partner with others through knowledge management and use that for the betterment of overall health in Alaska. But Aaron, go ahead.
Yeah, I don't really have a whole lot to add. I think it's you know, what's cool about Alaska is it's just the geography is a super big challenge, right? So you've got you know, relatively small population spread over a huge distances, and so it's the best case scenario for kind of really trying to make telehealth work, for instance, and digital work, and you know, and trying to make the we have a phrase that we kind of borrowed from Amazon here. At Amazon, we talked about self-service is the best service. You know, we've modified it for healthcare, that safe self-service is the best service. So wherever possible, you know, can you provide kind of 24/7 non-geographically challenging kind of digital services that that, you know, a patient or a consumer could kind of manage themselves, just like you can do online banking and those types of things, where you know, we're again removing all the friction between the patient and receiving the care they need.
Well, once again, gentlemen, we've hit the top of the hour. We've only got a minute or two left here, and we deeply appreciate you sharing your times for Alaska, and particularly challenging times for the healthcare industry. And we deeply, deeply appreciate all the work that you and your team do to help us get through these difficult times. So again, thank you. Thank you so much on behalf of the membership of AEDC for participating in today's AEDC Voice. So I'm going to go ahead and wrap things up here, folks. We want to thank our good friends, Paula Bradison and her team at AES and BMG for their ongoing sponsorship of AEDC Voice. We'll be back again next month with another great speaker. And with that, we'll thank you all for participating today. Enjoy your day, be safe, and remember, wear a mask.
Thanks. Take care. Be safe.